ACL STARR, we have been funded both in the UK and Australia for anterior cruciate ligament stratified accelerated repair, single-blind randomized control trial for patients with proximal tears, repair versus reconstruction. So it's in patients 14 and above with proximal tear patterns as identified on MRI. We're hopefully going to do it in 20 plus sites across the UK in 214 randomized patients. We're going to recruit more because we appreciate that at the time of surgery and intra-surgery randomization, people may think the tissue quality isn't acceptable for repair. It's a functional outcome as a primary outcome of a Q score at 24 months, the whole raft of secondary outcomes, funded fully in the UK and Australia and being run between Cambridge and Oxford trials unit. So the key things for the study with service improvements, this is not straightforward primarily because of the NHS pressures, and that's one of the reasons that we're keen to run it in Australia as well, to see if a different health economy can actually treat these patients better, and is it the later surgery which is going to be the problem. So acute knee clinics, urgent MRIs with identification of tear type, stratification, and then it's scope first before randomization, and then to decide if it's repairable or not repairable. We're also including lateral extra-articular procedures to be included in that stratification pragmatically, and then repair versus reconstruction. The techniques described are the ones that have had plenty of cohort studies and literature, whether it be the internal brace, the ligger brace, or anchors in the lateral wall, with or without a tenodesis. Again, this is the cinch sutures being brought up to the lateral wall, and then the anchors in the lateral wall. For the reconstruction arm, we're using hamstrings, as this is a technique that is familiar to the majority of orthopedic surgeons. Again, we're being pragmatic about the technique of hamstrings with tenodesis. So it's going to be blinded as best we can. We appreciate that there are scars and different outcomes that the patients are going to be told and consented for ACL surgery and not aware of which technique they have had at the time of surgery. This is surgery versus surgery. And again, the rehab, all patients are going to have a controlled, matched rehab pathway, so that doesn't become a confounding factor. Got lots of interest around the UK. We're going through ethics this month, hoping to start in February. So in summary, ACL repair, or when? Well, if in anyone for proximal tears with good tissue quality within 50 days. Where to do it? Well, within the remit of a clinical trial. So if people are interested, please get in contact. And how? Well, we're being pragmatic about the approach. We're not one specific industry or company or other, including a tenodesis as a pragmatic approach to that as well. Thank you.